Welcome back to Anatomy and Physiology, Chapter 12. This is the Articulations chapter continued. In this lecture, we're going to be discussing specific joints of the body that were named in your lab manual, as well as movements about specific joints, and how to describe these movements. The 5 joints we're going to be covered are listed here: temporomandibular, glenohumeral, acetabulofemoral, humeral ulnar, as well as femorotibial. The temporomandibular joint is the only diarthritic joint found within the cranium and the skull. It is found between the mandibular fossa of the temporal bone and the condylar process of the mandible, and is present in the 2 pictures below. The glenohumeral joint, often called the shoulder joint, is a joint found between the head of the humerus and the glenoid fossa of the scapula. This is a ball and socket joint. It is very mobile and flexible, and easily damaged and dislocated. As you can see, the large head and the small glenoid cavity is what allows this joint to become dislocated or damaged very easily. Next, the acetabulofemoral joint is found between the acetabulum and the head of the femur, very easily identified on the picture to the right. Associated structures of interest that we're interested in are the acetabular labrum. This is a connective tissue bundle that makes the acetabulum deeper, provides a lip per se, and the round ligament, or the ligamentum teres. This is a thick ligament that holds the head of the femur into the acetabulum. As you can see in this picture here, the ligamentum teres has been cut, but it extends from the fovea capitis of the femur into the deep socket of the acetabulum. You can also see the articular cartilage present, makes a very distinct horseshoe shape on the acetabulum, and then there is a picture of the acetabular labral tear. So you can see that the labrum here in the acetabulum actually extends the cup up even farther. The next joint is going to be the humeral ulnar joint. This is commonly called your elbow joint. This is found between the trochlea of the humerus and the trochlear notch of the ulna. As you can see in the pictures below, the trochlear notch is a deep impression found within the ulna, and the trochlea is on the distal end of the humerus. The femoral tibial joint, this is found between the condyles of the femur and the condyles of the tibia. This is the largest and most complex joint that we talk about. Major ligaments associated with this joint that you'll need to know are the anterior cruciate ligament, the posterior cruciate ligament, and the medial collateral ligament, as well as the lateral collateral ligament. Now, know that on tests and during final exams, you do not use the abbreviations of these as ACL, PCL, MCL, and LCL. I want to know that you know that anterior cruciate ligament is exactly what it is, and not just the ACL. In this picture here, you can see an example of a knee joint or a femorotibial joint. You can identify the posterior cruciate ligament and the anterior cruciate ligament very easily. They are in the middle of the joint, and they make that cross there, which is where cruciate comes from in their name. You can see the menisci present between the 2 condyles of the femur and the tibia. And on the medial side, you can see the medial collateral ligament. The book also refers to this as the tibial collateral ligament. The lateral collateral ligament you see on the left side of the screen. This is also termed the fibular ligament or fibular collateral ligament. So this is an anterior view, and here's a posterior view. You should be able to identify all of these ligaments from both an anterior and a posterior view, as well as the menisci. If you look at the picture and you see the fibula, it should be on the lateral side. So this is how you should be able to identify lateral from medial. So again, you can see the cruciate ligaments. Here they don't look like they make so much of a cross as they do from the anterior side. And you can also see the collateral ligaments as well as the menisci. 2 of the most commonly replaced joints are going to be the knee and the hip joints. where 90% of all the patients with hip prostheses will be pain-free and ambulatory-free after 10 years post-operation. That's a long time. Most joint replacements use a polyethylene for the bearing surface and either a titanium alloy or a chrome cobalt alloy for the rest of the joint. Here's an example of a normal versus arthritic hip. Where the arrow is pointing to on the left, you can see a good joint space between the two bones, and on the right hand side you can see that the two bones are actually making contact. You can see why arthritic hips are very painful. Here you can see an artificial knee, again with a titanium alloy on the femoral condyles, and on the tibial condyles you can see the polyethylene bearing type surface. Notice how they had to cut away the bone in order to create the condyles themselves. It's very common. When you look at creating a hip, there's actually a large spike that is driven down deeply into the medullary canal of the femur, which you can see here on this screen shot. Now we're going to talk about movements. We're going to be able to describe joint movement, tell whether it increases or decreases joint angle. We can talk about rotation about a joint. And a good way for you to remember these is to think about them when you're out there walking around, moving, lifting things, working out, whatever it takes to help you remember these. Flexion, extension, and hyperextension. These are some of the most common movements that we do on a daily basis. Flexion always decreases joint angle. So bending your elbow at bringing it up towards your head, as in the picture to the right, is flexing your elbow. And then going from that flex position back down to anatomical position is going to be extension. And then hyperextension is the extension of a joint beyond its anatomical position. So anytime you go into the posterior anatomical plane, you're hyperextending, as you can see with the wrist or carpal joint below. You can also flex the spine. So here you can see the young lady bending over, flexing her spine. You have shoulder flexion, where she's lifting her arms straight out, as well as spinal extension, where her back is now become straight, and then hyperextension of the neck, back, and shoulder, where she is extending beyond anatomical position. Abduction and adduction. Abduction is movement away from the midline of the body. So if you can remember that aliens take you away, they abduct you. That's movement away from the midline of the body. And then adduction is movement towards the midline of the body. So you can add to your midline. Here you see abduction and adduction of the phalanges. There is lateral and medial rotation. Anytime you rotate your head or a joint away from your midline, it is going to be lateral rotation, so you turn the bone outward. And anytime you bring that back towards normal anatomical position or rotate beyond toward the midline even farther, that is going to be medial rotation. Supination and pronation. This occurs only in the forearm and in the foot. So supination, you can see, is when your palms are facing forward, as in normal anatomical position. When you turn your palms, rotate them toward the posterior side, that is pronation. If you hold your hand up with your elbow flexed, and you imagine you're holding a bowl of soup, that would be a supinated hand. And then if you pour that bowl of soup out, it becomes pronated. Just something to think about with your hand. Protraction and retraction. Protraction is movement of the bone anteriorly on a horizontal plane, so forward. So by thrusting your jaw forward, or your shoulders, or your pelvis, this is all protraction. And retraction is the movement of the bone posteriorly. So how the picture above, how he pushes his jaw forward and then pulls his jaw back. It's protraction and retraction. Inversion and eversion. This is also known as supination and pronation in the feet. Inversion is a movement in which the soles are turned inward or medially. Eversion is turning the soles to face laterally. Inversion and supination can be used interchangeably, as well as eversion and pronation in the feet. Opposition and reposition. Opposition is the movement of the thumb to approach or touch the fingertips. This is what gives us our opposable thumb. Reposition is the movement back to normal anatomical position. This also allows the hand to grasp objects. Dorsiflexion and plantar flexion. The dorsal side of your foot is the most superior side. It's the top of your foot. The plantar side of your foot is the bottom or the sole of your foot. So dorsiflexion is when you raise your toes forward and upward. Plantar flexion is when you point your toes downward. This is a very important movement in bipedal motion. So this is the end of chapter 12. Be sure to study and know all of the actions described and be able to name joints, along with what type of joint they are from part 1 of Articulations. Thank you and have a good day.